Hi everyone, welcome to Unmasked with Casting and Megan. I'm your host, and today we have a special guest, Dr. Sadler, who is a amazing neurologist and is here to share with us some of his knowledge on EEGs. So Dr. Sadler, do you want to give a brief introduction of yourself?
Oh, well, what can I say? Yeah, I am a neurologist, that's true. Yeah, my name's Mark Sadler. I'm a neurologist. I'm just at the tail end of my medical career at the moment. I'm as of the 1st of July this year, I'm no longer doing any more outpatient work and seeing any outpatients or doing any of that kind of stuff. I'm still the attending physician from time to time on the epilepsy monitoring unit here in Halifax, and that's going to come to an end in about 3 weeks, and then I'm completely retired from practice. But over my career, my major areas of interest in neurology have been epilepsy, EEG, surgical management of epilepsy, and so on and so forth. So I've had an appointment at Dalhousie University since 1988. Before that, I was in Newfoundland from 1983 to 88. And in the time that, pardon me, the time that I've been here, the group that I work with, which is an absolutely spectacularly good group, we've slowly built up our expertise, our added technology. We've developed, really been very, very pleased with the development of our epilepsy program here in total. And this is very much a team thing involving the EEG technologists, the neurosurgeons, my colleague Susan Rahe for so many years, the nurses in the unit, and many, many others, the neuropsychologists, all kinds of people. So there's lots of people in this group, of which I'm only one cog, one small piece of that. So yeah, so I got interested in epilepsy when I was training in London, Ontario in the early 80s. And they, at that time, were developing their epilepsy surgery program. And it turned out I just had an innate interest in epilepsy and EEG. And yeah, that's, I don't know. Anything else you want to know?
That's great.
Okay.
So one of the first questions that came through was, what is an EEG?
Okay, sure. Well, EEG is recording of electrical signals from the brain. And that's important to always bear in mind because it's very different from some of the newer techniques in neurology and neurosurgery of imaging, like magnetic resonance image or an MRI scan or CT scans, which show what the brain looks like. So the EEG records electrical signals, and because the brain works as an electrical organ, and we can talk about that in a second, the EEG is a test of brain function, not structure. MRI, which many of you people know, shows us what the brain looks like. The EEG records the electrical signals to tell how it's functioning. Now, maybe we could start at a really elementary level for a moment. The brain, the EEG records electrical signals only from the surface of the brain. In other words, the top several millimeters of the cortex, which is the very surface part of the brain. And that's, that part of the brain is where individual brain cells, neurons, reside. There are other places in the brain where there are brain cells, but the surface of the brain is where, for our purposes, the major action is. And if we think of one single brain cell has a cable that comes from it that we call an axon. And that axon takes information from that one cell to many, many other neurons or brain cells. And each of those brain cells that it connects to have connections with tens of thousands, maybe hundreds of thousands of other neurons. So if we think that there are, maybe let's take a number, 100 billion brain cells in the cortex, and each of those brain cells connects to thousands and thousands of other neurons, you can start to see how complicated the wiring, if you like, of the brain is. So getting back to EEG, whenever one of these axons, that's the cable that comes from the brain cell, goes and connects to another brain cell, there's a very small electrical current that's generated, very, very tiny. And it's those currents, electrical currents, that are generated by the billions and billions of brain cells are the electrical energy that we record in an EEG from the scalp. Okay? So maybe before we leave that and go on to a little more, I'll just stop and ask if there's any questions about those basic principles before we go further.
I'm just reading through the questions, see if they relate to that.
Okay. Well, if there's no burning questions on those very simple things, then we can move on, I guess. So we have a way then, and EEG or electroencephalography, and the E that would give you a clue as to what this test is about. It's electrical, and the cephalo part refers to brain. So this is the electroencephalogram. So this is a really old technique by our modern standards, because the first brain waves were recorded way back in the 1920s in Germany by a guy named Hans Berger. And at that time, he was the first, he's credited with having recorded the first electrical brain waves from humans, okay, as opposed to earlier work that had been done in various animal models and so forth. So Berger recorded these things, and it's an interesting story. He was a German, basically a psychiatrist, but he was interested in neurophysiology, or how the brain works, and the equipment that he had was very, very simple. Only one channel, and what I mean by that is he would have one electrode on one part of the scalp and maybe one other electrode on another part of the scalp, and that was all he had. And he would record the electrical energy between these two places. And despite the very, very primitive equipment that he had, he was able to conclusively demonstrate that there were electrical signals coming from the brain that could be measured from the scalp. So this was a ginormous step forward, even though his work wasn't really all that appreciated in the early 1930s. And it wasn't until other investigators replicated his results that the whole field of EEG took off. And because it was an early technique, this would be long before any CAT scans, the methods of looking at the brain were not very sophisticated. You had skull X-rays and EEGs, and not a whole lot else from in those early days in the 1930s, 1940s, and so on. So because this was a new technique, it was applied and studied in many, many, many different neurological conditions, whether you had Parkinson's disease, Alzheimer's disease, migraine, various psychiatric disorders, epilepsy, and all kinds of things. And then over time, as other tests became available, we, like CAT scans and MRI, we began to appreciate where does EEG fit in different types of neurological disorders and so on. So I guess the next major step was in the 1980s, when computer technology came along, and this was just unbelievable for people like myself who were used to the old style of doing EEG. And some of the listeners or yourself, Cassie, may have seen old movies or old things of pens scratching out on paper with ink on paper, these long rolls of paper, the EEG signals that we were measuring. And that did the job, and the fundamentals of EEG were well established before computers came along. And those recordings back then were really the foundation of all the stuff that we still do. But the problem with writing things out on paper is you can't do anything with it after it's down on the paper. It's a little bit like you writing me a note on a piece of paper, and then versus you writing it on PowerPoint, or excuse me, on Microsoft Word or something, and you say, "Oh, I'd like to put that in italics, or I'd like to change the size of that font, or underline that word." Well, after you've written it down on paper and sent it to me, you can't do anything with the written word. This was the kind of problem we were dealing with the paper, that you couldn't do anything with it after it was recorded. The second thing is storage. And a typical EEG recording back on paper was large paper, and each recording would be about this thick at the end. And in the lab where I started working here down at the VG Hospital in Halifax, we would have a room that would be filled with EEG recordings that space would fill up in a year. Okay, so whereas nowadays we have limitless space because of the computer technology. You can record EEG using improved electronics, and then the actual signals do not get recorded on paper. They're electronically fixed on in the computer. And very importantly for us, there's ways of looking at the EEG after it's been recorded. You can do things. You can twiggle, push buttons and change knobs and make the waveforms look different and so on. So those were two huge steps forward in the 1980s with enhanced computer stuff. So probably many, if not all, of the people that are tuned in have an EEG, so that have had an EEG recording. So should we talk about how it's done? Is that where we should go next?
Yeah, a lot of us have. There was one question, trying to find here. So the EEGs for humans was invented in the 1930s. It has evolved since then to provide a better brain electrical insight with new sub-scalp EEGs. What can these show that a regular EEG can't?
Well, the main, let me see, there are lots and lots of experimental techniques that are used by computer software people to see if we can milk more information out of the EEG than what we see with the human eye. And maybe what I should do is I'll go back a step. I talked about how a little bit about how we record this stuff, and what we ended up is all these little squiggles on a computer screen. But the vast majority of interpretation, in other words, what does somebody like me, trained in EEG interpretation, how do we do it? Well, essentially, it's us looking on the screen at these patterns and trying to recognize by our own training and experience, what is it that we're looking at? The some of the new experimental techniques are taking the EEG signals and analyzing them with various software programs to see if things can be measured in there that will that escape the human eye. In other words, that there's patterns in there that we, with our brains and our eyes, just cannot recognize. So that's probably a considerable future in this. And people, because at the moment, there's still a lot of what we call subjectivity in reading EEG. In other words, I might sit down with one of my colleagues and we might look at this EEG and I might say, gee, what do you think of this? And they'll say, I think it's this. And I say, well, I'm not so sure. I think it might be that. And so there's lots of judgment calls and so forth. Perhaps with enhanced computer techniques, it'll remove some of that subjectivity. And the computer will say, no, this is a 99% chance that what we're looking at here is whatever, okay? So that's where some of the future of EEG will be. And maybe I'll just bring it up in the moment now, that one of the things that we do, of course, is with very long recordings. For those of you who have been in an epilepsy monitoring unit where you're recorded 24 hours a day, day after day, we already have some computer techniques that allow the computer to look at 24 hours of EEG very quickly, as opposed to me sitting and looking at one page after another, and we don't look at 24 hours worth of recording. We ask the computer to help us find things that the computer thinks are abnormalities, and we look at those. So those are some of the computer techniques that are currently in use. So getting back maybe to just some basic principles again for a moment. So for the vast majority of EEGs that are done in the world, people come to an EEG laboratory. And in our part of the world, it's virtually always in a hospital setting. In other words, there's a laboratory, a space within the hospital where people come to have this kind of test done. In other parts of the country and very, very many places in the world, there are private facilities where people have private EEG labs in standalone offices and so on, where this is done. And that tells you a little bit about how one of the things about EEG is that in comparison to other tests in medicine, this is relatively inexpensive technology, all right? As opposed to having a huge MRI machine in your office and stuff like that. This is relatively inexpensive technology. So you can do it in different settings. But anyway, people come to the lab, and then the EEG technologists, who are very highly trained folks, will do the actual recording. So unlike some procedures in medicine where a physician actually is doing the test, we don't need the physician to be present when the EEG is actually being recorded. So the technologist starts by taking a history from the patient to get some sense of what it is, why this test has been ordered by the physician, and to have some, so the technologist has some idea of what they're going to be perhaps looking for. And then a series of measurements of the head are taken. And the reason we do that is that the EEG is recorded by little small metallic electrodes that are stuck on the scalp, on the skin. And those electrodes are not just placed willy-nilly, any old place. There are very precise places where they are put. And a very elegant system was developed in the 1950s as to have an international standard for electrode placement. In other words, that if we decide we have a system where measurements of the head are taken, the technologist does that, and then puts the electrodes in all these different places. And at the same time, the naming of these positions is also an international standard. So that, as an example, electrode F3, this is in the left, because we know it's left because the number is 3. It's an odd number, odd on the left, even on the right. F means frontal, and there's a very specific location to put F3 on, whether you've got a huge head, little tiny head, child, adult, whatever, and that the position F3 in France is the same place as the F3 in Halifax. Okay, so that system of this is a Canadian. Well, strictly speaking, he was American, but he did all his work at McGill at Montreal. Herbert Jasper was the principal author of what we now know as the International 1020 System of Electrode Placement. Okay, so the electrodes are put on, and then there's some techniques used to make the contact with the skin better, so that there's a little bit of gentle scraping of the scalp, and then some little bit of electrolyte solution is put in so that the electrode is able to detect these very, very tiny electrical signals that are coming from the brain. And then those wires are fed into an amplifier. The amplifier is a very high-grade electronic device that amplifies the signal so that we can then see it. The patient typically lies down or reclining in a relaxed space. The technologist asks the patient to typically close their eyes and just relax. And one of the things that may not be so obvious to your listeners, to our listeners, is that one of the things that EEG detects is not only brain waves. We have to deal with all kinds of what we call artifacts. So people shaking their head around, blinking their eyes, swallowing, coughing, chewing, moving. To have the patient in what we call relaxed wakefulness. And if they happen to drift off to sleep, so much the better, because the EEG signals in sleep are different than wakefulness, and so on. And then a typical recording session is about 30 minutes or so, okay, of actual recording time. So there's the setup at the beginning where all the measurements are taken, electrodes are put on the scalp, then the recording time of about half an hour or so. And most of that is the patient lying quietly, not doing anything. And then we have what are called activation techniques. And for those of you who've had EEGs, you know that a standard outpatient recording will get you to breathe deeply for about 3 minutes or so. And sometimes that activates certain seizure types or certain EEG patterns. And then there's what's called photic stimulation, where the patient has a strobe light put in front of their face, and then the strobe light, it flashes at certain frequencies, and we start very slow, and then we gradually speed it up. And once again, that is what's called an activation technique to see if we can pull out something from the resting EEG that we don't see otherwise. And then, the recording's over, and then you got all the goop in your hair, and you got to comb it all out, and it's a big mess and all that kind of stuff, and which most of you are very familiar with that end of things. So that's how a standard outpatient EEG is recorded. And then what happens is that information is stored on the computer and available for viewing by the person who's going to interpret it. And it's what we call an electroencephalographer. So an electroencephalographer is somebody who's had special training in EEG interpretation and can look at all these little squiggles and wavy lines and try and make some sense of them. So not all neurologists read EEG. All neurologists in their training to become a neurologist have exposure to EEG. They come, the residents, the neurology residents rotate with us, and they may spend 3 months with us, or maybe 6 or something like that. So they have some familiarity with it and so on. It's people who are destined to have a subspecialty interest in EEG and epilepsy have to do additional training beyond their 5 years of neurology training, usually, to read EEG satisfactorily. So that, and that's the way it is pretty well in Canada. There are a few, but very, very few other people that really read EEG for clinical purposes in this country. The vast majority are neurologists with extra training in EEG and so on. So generally speaking, nowadays, as compared to the 1950s, we don't have psychiatrists reading EEG much anymore. And neurosurgeons typically do not read EEG anymore. They do what they do, and we do what we do, and so on. So so when we sit down to read the EEG afterwards, so the patient by this time has usually gone home, and we sit there and we flip through the 30 minutes of the recording, looking for abnormalities and so forth. Then we generate a report, and that's how your standard outpatient EEG is done. Okay. Any questions about that so far?
Excellent. That was a great answer. Looking at the questions, so a question, another question. Was that my question? Someone else?
Just as a question.
Okay. Another question is, so I know you talked about the electrodes.
Yeah.
But what are the different types, and how do each one work?
Okay.
And
so, yeah, go ahead.
EEGs.
Okay. So around the world, there are different types of metallic electrodes that are used on the scalp. And those just reflect different practices, different types of metals. Each of these has slight advantages over others, and so on. And over time, different companies that make EEG electrodes have changed things a little bit. Very recently, we've been forced by the world we live in nowadays to go to disposable electrodes. So the electrodes that we're using now are one use only, and then they're discarded. And in the past, electrodes were used, and once they were used once, then there was a very thorough cleaning process by the technologist to get rid of the paste, the electrode paste, and so forth that was used, but mainly for so that they would record well on the next patient, but most importantly for infection control. And so so once various viruses and the worries over HIV, hepatitis, et cetera, came along. Basically, the process of cleaning the electrodes and all that kind of stuff is time-consuming, it's expensive, and so on. But the infection control people that we respond to have said we have to go to a disposable electrode. So now we're using disposable electrodes. Now, the question the question for different types of electrodes may have been also directed to very special circumstances of when we put electrodes in the brain or inside the head. And so what we're talking about there is, and we're jumping ahead a little bit, but I'll try and come back to it in a little while. When we have patients who are candidates for surgery to see if we can relieve them of their epilepsy, one of the techniques that's done before the surgery to try and sort out where do the seizures come from is a process called intracranial EEG. And intracranial means inside the skull. All right. So that, as we've spoken about, our usual way is the outpatient procedure. Patients come in, they have electrodes in their scalp, blah, blah, blah. But when we go into the world of invasive or intracranial EEG, there are ways of drilling holes in the skull and placing electrodes, very tiny electrodes, very tiny little wires, into very specific targets in the brain. And this is a very different technique than what we've been speaking of to this point, because in this situation, we don't have a standard placement of electrodes. Remember, we were talking about how outpatient records, everybody has electrodes in the same place in the head, et cetera, et cetera. When we go to this intracranial recording, we have already decided by the type of seizures the patient has, their MRI scans, and a whole bunch of other factors where we think the seizures are probably coming from. Then we often have, well, if they're not coming from place A, maybe place B, which is very close, is a possible. Maybe there's place C, etc. So what we do is we place a number of electrodes in the brain in the areas that we are that we have an idea about. In other words, what we call a hypothesis. That we have to have a good idea of where we think the patient's seizures are coming from. And then when we go to this kind of recording, this is very complex, next level up, if you like, EEG, where ahead of time the patient's had a very sophisticated MRI scan that shows very fine detail of the brain. And we have a conference where we sit and talk with the surgeons, and we say, we think that the patient's seizures are probably coming from here, or maybe there. And we ask the surgeons, do you think that you can put an electrode in the brain there, and there, but we don't need any over there. So in this situation, the planning is all done ahead of time. Then the patient comes to the hospital, comes to the operating room, is put to sleep, and then the placement of electrodes is done by the surgeons, and this is very, very precise kind of neurosurgery, where just to give you an idea about this, we design the implantation or the putting of the electrodes in. It's an accuracy of a couple of millimeters, 1 or 2 millimeters. That's what we aim for. It's not, oh, well, anywhere over here will do. Put one over there. Yeah, that's not a bad place. It's very, very precise where we want these. And then, as you can imagine from this discussion, once you take a patient, put them to sleep, drill holes in the skull, put electrodes in the brain, and then start recording them in the epilepsy monitoring unit, this has some risk involved, as you can appreciate. You can't drill holes in people's heads and put them to sleep, give them general anesthetic, and put wires in their head without some degree of risk of hemorrhage or infection, and so on. And on balance, this is a very safe procedure, and so on. But there's always a very small percentage of people who could have trouble as a result of that. This is very different from our outpatient recording, or really, for practical purposes, our inpatient epilepsy monitoring unit from the scalp. So those are a couple of different types of electrodes.
Okay, excellent. Greg had a question about, like, when you're talking about the in-depth and the surface ones.
Yes.
He asked, if the seizures originate not from the surface of the brain, but deeper, how does that show clearly on an EEG?
Okay. Our concept in the 2000s basically is that all seizures come from the surface of the brain. Okay? They do not originate in deeper structures. Seizures can start in the surface of the brain and then spread to deeper structures, but we do not believe that deeper structures initiate. In other words, one of the retired neurosurgeons in Montreal used to have an expression for the place where the seizure starts. He used to call it the detonator, okay, like a bomb. And so the detonator in epilepsy is still felt to be in the cortex or the surface of the brain. All right, and that's actually a really, really fundamental idea, because in the late 19th century, in the 1800s and so on, people had no idea where seizures came from. They didn't know if they came from the deep structures of the brain or in parts of what we call the cerebellum, another structure in the back part of the brain, or where. But it's pretty clear now that seizures start in the surface of the brain. Now, if you can imagine, and unfortunately I don't have a picture to show, but the brain, if you can imagine two halves, a left and a right, and then in between the left and right side, there's surface of brain there, but it's folded down. And that's a difficult area to see. It's still surface of brain, but it's turned inwards so that it's a little deeper, but it's still surface of brain. And though that's an area that is really a problem for us in sorting out where seizures come from, because from the scalp, this area in the midline of the brain is very difficult to record from the scalp. So we have to make some educated guesses sometimes about where to put electrodes in those people.
Dylan had asked like the difference between the surface EEGs and electrodes and the implanted ones. So you did a great job of answering that question earlier. I'm looking. I've answered a lot of the questions so far. So say someone was having an EEG and they had a seizure during it. What would be your guys' protocol, or what would you do if that were to happen?
Okay, all right. So that opens up another area of discussion. That's great. First of all, let's stick for the moment with just regular outpatient EEG. All right, where a patient and let's say we're talking exclusively about people who have epilepsy, might have epilepsy, it's thought they could have it, whatever. And the physician orders an EEG. So the patient comes for the recording, and as we've already discussed, it's about 30 minutes. And this is a really, really important point for people to appreciate. We're not actually anticipating that the person is going to have a seizure during that 30 minutes. If it happens, that's just luck, either good or bad, depending on how you look at it, okay? It may be good luck, and the point of it will make a diagnosis and make everything clear, or bad luck for the patient or whatever. But the idea here is that during that, and we're going to go back and I'll try and give one of my usual explanations about seizures in a simple way. And often I tell patients that think of a seizure as being like a forest fire. All right? So we've got a forest, which is the brain, and the seizure can start in some place in the forest, in some very dry little area where hasn't got any rain for a while and that kind of thing. And somebody drops a match or gets hit by lightning or something happens and so on. Now, in this analogy, there may be some sparks from this area of the forest, right? Once in a while, you could walk by and see a little puff of smoke, a few sparks there, but the fire actually hasn't started yet. These little sparks, this is what we're usually looking for in that half hour of recording when a patient is having a regular outpatient EEG to see if they have epilepsy or not. In other words, do they have any of these little sparks occurring from time to time on the brainwave test that tell us this patient probably has epilepsy, all right? Now, this is just a small sample in time. 30 minutes of recording time, it's nothing, right? And it's, I think it's extraordinary that we can do anything in the 30-minute recording time with 21 electrodes on the head, sampling billions of neurons and trillions of connections, that we can see anything at all. So, it's kind of neat when you think of it in that way. But in actual fact, what happens is patients with epilepsy can have these little sparks coming from the cortex that you can record in between seizures. And that's usually what we're looking for, to give us a clue that the patient does have epilepsy. Now, the reason I wanted to harp on this for a couple of minutes is because it's, if you're walking down the street and you see somebody who has a very clear seizure in front of you, and then a few days later they go for a brainwave test, an EEG, and for 30 minutes their recording is done, and let's suppose it's, quote, normal. Does that mean they didn't have a seizure or they don't have epilepsy? And the answer is no. It just means that in that little sample of 30 minutes, there weren't any of these little sparks. And different types of epilepsy have a tendency to show these abnormalities or not. Depends if the patient is on medication or not, from what part of the brain do these sparks come from. If they're very this place between the two hemispheres that I was talking about a few minutes ago, if the epilepsy comes from there and there's all kinds of little sparks happening down there, we may never see those up on the scalp. So it's a chancy thing. And so sometimes when we're quite convinced by the patient's history and what the patient tells us and what observer tells us, it's very clear the patient is having one seizure type or another, then sometimes we have to do multiple recordings. And sometimes we extend the recording time, not just 30 minutes. Why don't we take extra time in the lab, maybe record them for an hour, and record them in different states. What I mean by that is patients, we can, if they've had a normal EEG, but we're still very keen to pursue this, sometimes we do what's called a double-length sleep-deprived EEG. We record twice as long, and we ask the patient to stay up real late the night before so that they can come to the lab and drift off into sleep. Because there are some types of epilepsy that disclose their sparks, show their abnormalities better in sleep than wakefulness. And so that's another little trick we use to try and sample the brain that way. Now, getting back to the question, if you have a seizure during the recording, what do we do? Well, the physicians do nothing because it's all up to the technologists, right? So the EEG technologists are trained to respond with proper first aid techniques because it's safety first. We make sure the patient is safe, or the technologists make sure the patient is safe. And then the technologists are also very well trained in seizure recognition, what type of seizures the patient is having, and they may interact with the patient to ask them some questions and get some very valuable information in addition to making sure they're safe and also ensuring that the recording continues. So so that's what's what if you have a seizure during the EEG. I'm not sure if that was really what the question was being asked. Yeah.
No, that definitely answered it. I'm glad you talked about how, like, if your EEG is phrased as normal or doesn't show any activity, that's like, it doesn't mean you don't have epilepsy, it just means there was nothing at that time. I
That's
know a
right.
lot of people get frustrated with that, and that they had no activity while in EEG, and then they go home, and then they have like 3 or a bunch. So I guess do the people usually have them when they get home? Or like, how do you know? I mean, do you know like why that happens?
I'm sorry, Cassidy. Do they usually have? I'm sorry, I didn't quite follow that.
So I guess it was the question that came in last night. It was a lot of people find that like they go for those EEGs and like their EEGs come back as normal,
Yeah.
and then when they get home, they have a seizure. Is
Okay.
there like a correlation between the two, or?
No, that's just bad luck. Okay, that's just bad luck. And this is one thing that I think is really important to emphasize, that in the 2000s, epilepsy and seizures are still defined clinically. In other words, it's what the patient experiences, what they tell us they experience, and what an observer sees, okay? That, in other words, and the reason for this is that the vast majority of people who have epilepsy probably never have a seizure recorded in an EEG, okay? Because they may have the little sparks demonstrated on the EEG that are abnormal, but they don't necessarily need to have a recorded seizure to prove that they're epilepsy, okay? That they have epilepsy. Similarly, there are patients who have multiple EEGs that are always normal. But nevertheless, if the description is good and you have a good witness and very clear description of the events, we rely on the patients, and the descriptions have much more importance, much more weight than the test itself, okay? Now, there are very special circumstances where you can't tell, right? Because as you may have heard me say before, Cassie, the brain is a complex place, right? And we have there's a large number of different seizure types, and the expression of seizures from the brain can be very varied. And that's not surprising because the brain is such a complicated place. So seizures that start in one place and just stay there, or stay there and then spread, the way it affects the patient, the way they feel it, and what an observer sees can be really quite different. So, but there are patterns, okay? There's not 10,000 different types of seizures. And the clinical description is still way more important than the EEG, okay?
Okay. One other question kind of leads into that. Is within the EEG, does the doctor or the patient decide if it's a short one, 24 hours, or long term?
The physician decides what is the, it's like pretty well everything else in medicine. You have this huge number of different kinds of tests and things that we can order, and so that typically and when you have limited resources, in other words, that we don't have 55 EEG technologists, 300 EEG openings, we don't have 50 or 100 bed epilepsy monitoring units, that kind of thing. You have to decide what test is best for that patient, and so on. So typically the physician decides what they think is the most appropriate investigation to do for the patient. And this area, I and my colleagues, we have real special expertise in this. So it's usually the epilepsy expert people who are usually deciding, look, we better spend some extra time and money and effort on one of these double-length sleep-deprived records, or this patient is a good candidate to come into the epilepsy monitoring unit where we're going to record 24 hours a day, day after day. That's expensive, okay? Because there's a world of difference in cost between having a outpatient 30-minute recording versus the cost to the healthcare system of admitting a patient to the monitoring unit where we have nurses and hospital beds, all the stuff that goes with the cost of being in hospital. So we have to, the buzzword, if you like, at the moment is choosing wisely, okay? In other words, if we have limited resources and limited finances, we should choose wisely. Pick the right test for the right patient and don't do just spend money doing things that aren't useful. So getting back to the question, it's the physician that typically decides what is done. Now, that's not to say that the patient can't ask and say, well, could I have this done? Why or why not? Should I have this done? Why or why not? No, it's perfect. That's the patient's right to ask, well, should I have this done? And what's the explanation, why or why not?
Excellent. And how often should someone get an EEG? I've had a few people ask that question to me. And
yeah, so couple things. Once upon a time, I'm talking about back in the 1950s, 60s, 70s and stuff, often patients every year they would have one. And I wasn't practicing medicine then, and so on. And I never really understood that. Nowadays, once a patient has their diagnosis established, there really isn't a good reason to keep doing more and more EEGs. We know what the problem is. And so usually there's not a good indication just to do it, just to sort of see what's going on in there, okay? It doesn't usually help. We should use the EEG to help with diagnosis. But once the diagnosis is made, if it's really secure, there really isn't a reason to keep doing it. Now, there are some circumstances where some physicians use the EEG in a different way. Let's suppose we have Mr. Smith, and Mr. Smith was diagnosed with epilepsy back when he was a teenager. Now he's in his 40s, and he has been taking some medication for 20 years or something, and he's had no seizures for 15 years or something like that. Some physicians will do a EEG to see, is there any trace of these sparks anymore? Is the tendency for having seizures still displaying it on the EEG? And if you do that, it would probably make some sense that if there's an abnormality, it's probably not a good idea for that patient to come off drug, right? So some physicians use the EEG as a tool to help with the decision about coming off medication. It's not that great a tool for this, because if you're thinking about what we've been speaking about, you could say, well, just a second. A little while ago, you said that there's lots of patients with epilepsy who have a normal EEG, and we know they have epilepsy and so on. So if maybe you're just unlucky in that 30 minutes of recording, if they've been seizure-free for 10 years, that they just didn't show any abnormality, and so you think that it's okay for them to come off drug, and they come off drug and they have a seizure, kaboom. That happens. So it's not a particularly great tool for helping to decide to come off drug, but it can be a little bit of help in certain circumstances.
okay, excellent. I'm glad you said that, because actually one of the questions Alila asked was if her daughter's been, he has been seizure free for 4 years. He has focal epilepsy, and a glossus in the occipital lobe, and they're wondering about reducing his medication without taking new EEG, since the last one was over a year ago.
So that brings to this, that comes to this question of can we use the EEG to predict seizure freedom if you come off drug, right? In other words, if you do an EEG and EEG is absolutely normal, does that mean for sure the patient will remain seizure free if they come off drug? In my opinion, no, it's not a very good predictor. On the other hand, if you do an EEG and there's a very clear abnormality present, I would be a little more reluctant about coming off medication. Okay? So I don't think it's a very good tool for predicting the future, particularly when it's normal. It might give a little bit of comfort, if you will, to the physician and the patient to know that it's normal. And this is another very important point, that as your audience knows, there's lots of different types of epilepsy. There are some types of epilepsy that very predictably go away. Certain types in childhood, by the time the person grows up to be an adult, that you can almost virtually guarantee that that type of epilepsy will be gone. And that's because of the type of the epilepsy. And it's not really the EEG that determines that. But, and then similarly, there are certain types of epilepsy that we say this person, no matter what their EEG shows, is going to have a pretty good chance of having seizures if they come off drug, even if they've been seizure-free 5 years or so. So lots of different types of epilepsy. These different types of epilepsy having a different, what we call prognosis. In other words, the outlook. The outlook can be quite different for different types, and the EEG is probably not the best tool for predicting the outcome. It's the type of epilepsy they have that predicts the outcome.
Okay, and so the manager from India had asked, what are side effects from EEGs?
This is one of the really great things about EEG. It is fantastically safe, right? So a person who comes for an outpatient recording and has the EEG test done, that is, I cannot think of a safer test in medicine than this, okay? In other words, the risk of an EEG is, it's the risk of crossing the street, coming up the elevator, being in a hospital, germs around. You know, I'm making this up a little bit, obviously, for fun. But the test itself is extremely safe, and there's no radiation involved. Okay, in other words, this is not like having a CAT scan. All right, it's not like having an MRI scan where the person may have some metal in their body. For example, somebody who has a pacemaker for their heart, to have them have an MRI scan is a very, very big deal. And there are some very serious safety issues that have to be considered and so on. The EEG, we don't have to worry about that at all. So I think from a practical point of view, we can say the risk of having an EEG approximates 0.
Okay, excellent. He had also asked if like EEGs could help diagnose people that have gone brain dead when in a coma.
Okay, yeah. It's an excellent question. So now we've moved a little bit from the application or use of EEG in epilepsy to the use of EEG in other neurological conditions, okay? And there are some. Okay, there are some. And a very common situation for us is a request from the intensive care unit or the coronary care unit for patients to have an EEG who have survived a cardiac arrest. In other words, a person who suddenly collapses on the sidewalk or in the hospital or wherever, their heart is stopped, an ambulance is called, they are resuscitated. In other words, their heart gets going again and their blood pressure is okay now and their heart's going, but yet they haven't woken up. And the reason they may not have woken up is because the brain does not tolerate the lack of oxygen at all, or well, for only a very, very short period of time. So that if the brain does not get sufficient oxygen going to it, there is brain injury and cell death occurring within minutes. Very different than other parts of the body, okay, that can tolerate the lack of oxygen much better. And as it turns out, the brain is, although it, I don't know, Cassidy, your brain probably is about 2% of your body weight, all right? But it takes up at least 20% of your whole body energy requirements. It's a high energy demand organ. And, and because of that, it needs a constant supply of oxygen, sugar, and other things to make it work. And if your heart stops and those things are not getting to the brain because the heart is stopped, the brain starts to die fairly quickly. So, but if you get the heart going again and so on, the question is, what is the outlook for this person? And the EEG is commonly used in that situation to help the physicians in the intensive care unit and coronary care units to know if the patient is in coma, and the EEG is a pretty good way of looking at how deep the coma is, okay? In other words, are they in a very deep, unresponsive state because the brain has been absolutely damaged beyond fixing or recovery? Or is it the patient is in the coma is not that bad, and there are certain patterns in the EEG that are quite predictive of a good outcome or an absolute catastrophe. Excuse me. In other words, a patient can have a cardiac arrest, not be woken up. 3 days later, their heart's going okay, their liver and kidneys are working okay, but the patient is still in a coma. The EEG, can it help us? And the answer is often yes. And we can often tell the physicians in charge of the patient that this patient has virtually no hope of recovery to living independently, that they have suffered irreversible brain damage. And then there's some obviously very difficult decisions to make with the family and the physicians. So now, one of the other questions, parts of the question, I think, was with respect to brain death. So in various countries in the world have different criteria that are used for this diagnosis of, quote, brain death. And in this country, in Canada, we almost never do an EEG recording for brain death any longer. We used to, but there are other ways of assessing the brain that are probably other techniques that are used that are probably easier, probably better, and so on. And there's a lot of technical factors here, and we probably don't need to get into those, but the EEG plays a very, very marginal role nowadays in brain death recordings. And we have a protocol in our laboratory that's very, very strict, very, very precise, very, very well spelled out protocol of how the EEG is to be done if it's a suspected brain death, and what steps have to be taken. And in a nutshell, just to give the audience a little bit a feeling about this, if you went and plugged in your stereo and turned the volume up as high as it would go, and you sat there and listened for 30 minutes or 45 minutes or something like that, and you heard nothing, that is the kind of thing that you're trying to accomplish by one of these brain death protocols. But suppose you heard just a couple little snaps, couple of crackles, couple of pops, and you're wondering, God, did that come from the brain or did it come from somewhere else? Sometimes you can't know, and so on. So these technical factors are really important in this in the EEG world, and it's one of the reasons that we don't use EEG for diagnosing brain death in this country very often. It can be done, but it's not the go-to thing. If we've done one brain death recording in the last 10 years at the Halifax Infirmary, I'd be surprised.
Okay. And what about like EEGs? Tell the difference between types of seizures and like what is an epilepsy seizure and what is not, or does it?
Okay. So maybe we can take a step back again, just for teaching purposes. That one of the ways, as many of your audience knows, very broad categories of epileptic seizures, what we call focal seizures that start in one relatively restricted part of the brain, versus what we call, quote, generalized seizures that seem to start in both sides of the brain at the same time, okay? That fundamental distinction is there because of EEG. It was the EEG that told us years ago, back in the 1940s, 1950s, that there are some seizures that start, that appear to involve both sides of the brain almost or virtually simultaneously, and it was deemed that these are what we'll call generalized seizures, and the other ones we'll call focal. And the underlying basis of those are quite different. The generalized seizures tend to be various types of epilepsies. In other words, there are a number of different types of generalized seizures, and within those generalized seizures, various subtypes. But the point is that the majority of those are patients who have a genetic basis for their seizures. In other words, it's down at the molecular chemical level of the brain, and those people do not have abnormalities on their MRI scans or anything like that, because the problem is at a genetic level. Versus somebody with focal epilepsy, where there's a certain part of the brain that triggers or is the detonator or initiates the seizure. And in those patients, they often have a very good reason why they have a focal seizure coming from that part of the brain. They perhaps have had a brain injury caused by a motor vehicle accident where they've had a skull fracture and the brain has been lacerated or cut or hurt. They could have a small brain tumor in that area. They may have had a stroke at some point in their life that gives a little scar in the brain and that generates the seizure. Those are just a couple of examples of seizure types that are, quote, focal. And in those people, the EEG tends to show these sparks, if you will, from that part of the brain. When the patient has a seizure during the EEG, as opposed to just in between, there's a whole series of different types of EEG patterns that we see. And that, and if we think of the brain undergoing this process, it's like an electrical storm, and the pattern, what we see on the EEG, it takes various different forms depending on what part of the brain the seizure started and where it spread to. Okay, and a lot of the time it gets really complicated because, as you know, that during a seizure, people are often moving, they're blinking, they're chewing, they're convulsing, etc. So there's a lot of these artifacts that I spoke about earlier in the podcast, where the EEG on the scalp records more than just brainwaves. It records muscle activity and movement and so on. So during a seizure itself, from a scalp recording, there's lots of different patterns that you see that you could say that's definitely a seizure or whatever. When we have the electrodes inside the brain, one of the great advantages to those is that you don't have so much artifact. These little tiny electrodes aren't recording muscle movement and eye blinks and that kind of stuff. So we can often see a very nice, easy to recognize seizure with these depth electrodes, but you have to be in the right place. We've had many, many examples of patients. We've had the electrodes in, clearly having a seizure. We look at their EEG and we don't see anything, okay? And it doesn't mean that they don't have seizures. It means we don't have the electrodes in the right place, okay? There was another part to that question.
The second part of the question was if EEGs could detect what seizures were epileptic and which ones weren't? Yeah,
we're pretty good at that, okay? We're pretty good at that. In other words, there are situations where people will have what we call non-epileptic seizures. In other words, a change in behavior that kind of looks like a seizure or may look quite a bit like a seizure, but is not caused by an electrical storm in the brain, okay? And this is a very, very common problem in our practice, and that patients with have what are called non-epileptic seizures, and the gold standard, if you like, for making this diagnosis, which is really important. It is so important to make sure that the patient does or does not have seizures. And I'll come to that point in a second. The gold standard is recording one of the patient's attacks with video. And I didn't really talk about that earlier, that nowadays, of course, virtually every lab in the country, I think, is certainly ours, we simultaneously video the EEG, video the patient, as well as record the EEG. So what the physician is actually looking at, we can look at the video of what the patient was doing during the EEG. So in the case of these non-epileptic seizures, we can look at the video, see what behaviors, what's going on with the patient, and look at the EEG at the same time. And because with experience, you know what seizures typically look like. So we've got the video part to look after the behavior part. The patient can describe sometimes what they're feeling, so that's good because we have the audio of the recorded event. And then we have the EEG part. And if you marry all three of these things together, particularly the video and the EEG together, I think we're pretty good at saying this was not an epileptic seizure. This was a behavior change that is not due to an electrical storm in the brain, and this is not epilepsy. It's in the non-epileptic seizure category. And this is so important because, like everything else in medicine, whether you've got belly pain because you ate the wrong food or you got appendicitis, you got to get the diagnosis right, okay? And getting the diagnosis right is the beginning of good medical care. When patients have non-epileptic seizures, it's really important because they should not be taking anti-seizure medications for a condition that they don't have. And they need expert management from skilled psychology and psychiatry people to help them deal with the features that, the problems that they're having that generate these non-epileptic seizures.
Excellent. I guess building on that, another question that came through the chat just while we're on the topic was, so if someone doesn't have a seizure during the EEG EMU but has abnormal brain waves, could that mean that they have psychogenic non-epileptic seizures?
In other words, yeah, the answer is yep, it's possible. Yep, and or no, or both, all of the above. All right. So let me elaborate a little bit on that. In the world of EEG, there are lots of what we call abnormalities, but they're not specific. Okay? What does that mean? Well, for example, there are certain patterns you can see on an EEG that if you look at it, you could ask an EEG guy, what do you think that is? And they could say, well, it's a non-specific abnormality. Let's suppose it just happens to be in the back part of the brain on the right. So non-specific abnormality. Well, the patient could have had a migraine attack at the time. They may have had a stroke sometime in the past. They may have had something else. It's a totally non-specific. It's abnormal, but not in a way that tells you what the problem is. This is different from what we call specific abnormalities. Specific abnormalities are EEG waveforms that are highly associated with seizures. In other words, if you take 1,000 people in a row and they people who have epilepsy will show this specific abnormality, and people who do not have epilepsy will not show that pattern. So there may be all kinds of non-specific abnormalities in between. So getting back to the question, patient comes to the epilepsy monitoring unit, has some abnormalities. Well, what kind of abnormalities are we talking about? If they're the non-specific abnormalities, they don't help us. If they don't have a recorded event during their epilepsy monitoring unit admission, you just say, I don't know. And this is a very difficult problem we have in the monitoring unit. How long do we keep somebody? A day, a week, a month, 3 months, 6 months? I'm just joking, obviously, here, but there needs to be a bit of a time limit on this, and it can be a real problem. Cassie, as you and the other folks know, probably lots of patients with epilepsy out and about doing their life. Even if they're not on medication, they don't have a seizure every day. They may go weeks, they may go months without having a seizure, even if they're not taking drug. So that if we have somebody come to the epilepsy monitoring unit and record them for a period of time, a week or 2 weeks, and they're completely off drug and they don't have anything, it still leaves the possibility open that they could have epilepsy, right? So no test is perfect.
Definitely understandable. I know some people have also asked, how can EEGs show activity yet the person themselves show no signs or symptoms?
Oh, that's a good question. All right, that's an imaginative question. One of the reasons, probably the easiest way to think about that would be there are large chunks of the cortex, the brain, whose specific functions are a little bit hard to define. Now, let me give a couple of examples. In the operating room, if the patient's brain is exposed, the skull's taken off, and you can see the brain there, and let's say it's my brain, and let's say this pen is an electrical stimulating device, and we put it on the part of the brain that's for movement, and we put it in a very specific place and turn on some electricity, we can get some twitches, say of my thumb. My thumb starts to twitch because we're electrically stimulating the part of the brain involved with movement. However, let's say we move to a different part of the brain and it's up, say, in the front here, and the patient is wide awake, alert, and we electrically stimulate there, and the patient says, hey, you say, do you feel anything? They say, nope. Okay. That doesn't mean that brain place has no function. It just means that for that kind of experiment of electrically stimulating that little tiny area, that it didn't cause the patient to feel something, nor did it give any outward manifestation. But it's probably got a job to do, otherwise it wouldn't be there, right? What that job is may be something quite complicated, and so on. So if a seizure starts in that area and just stays there, we might see that on the EEG, but the patient is awake and talking and feels nothing. So I'm fond of using little expression to explain things. It's like real estate, right? It's all real estate, location, location, location. Different parts of the brain have different jobs to do. And so seizures that come from one part of the brain, they cause different things. And there's lots of places in the brain that when the seizure is there and only there, the patient may not perceive anything. Unless, going back to the forest fire analogy, the forest fire spreads. In other words, the fire starts and up in the frontal lobe, patient may not have any symptoms, and they don't have anything until the seizure spreads to other parts of the brain that do have functions that are easy to see, like suddenly their eyes turn, or they stop speaking, or one arm elevates, or something like that.
Okay. So would that be why, like, some places are better on the scalp to place the electrodes during EEG than others?
Well, we try and sample everything we can with the scalp electrodes, okay? But and that's why, yeah. So we always have electrodes up in the front and all over the place. We try and have a pretty good, what we call a survey.
Okay. And Audrey had asked, so her son is 22, was diagnosed 5 years ago with chronic grand mal seizures. Nothing shows on the EEG. Sleep deprived, MRIs, CAT scans, PET scans. He's otherwise strong and healthy. He has refractory to meds. And the past year, he's been great drug controlled and seizure free since January. Her question is that they're cautiously optimistic. Should we consider him controlled? And how safe is he? He seems to be doing great, but on a lot of meds. She's worried about them becoming too complacent, although he's doing well. So, like, where he's been seizure free for a while on meds, would it be could they consider him seizure free and controlled, or should they still be on the wary side?
Yeah, boy, it's so hard, you know, and I really sympathize with patients who are in this situation. Okay, it's kind of obviously, and I'll say some of this just to to try and exaggerate it a bit. So if somebody's not had a seizure for 1 day, does that mean they're controlled? Well, clearly not. What about a week? Well, no. A month? Well, no, probably not. What about 6 months? What about 1 year? What about 2 years? What about 5 years? In other words, where do you make the cutoff? All right. And I guess, you know, probably most neurologists would, actually, a couple little points to go back on. It depends a little bit on how frequent seizures were occurring before treatment. Okay? So let's just suppose, as an example, suppose we have a patient who has had 10 seizures, 10 convulsive, generalized tonic-clonic grand mal seizures, let's say 10 in the past year, okay? And then you start them on treatment. And a year goes by with none. That's probably, you're probably pretty sure that whatever you did was the right thing to do, right? So if you had 10 in the year before treatment, started treatment, and then none for a year, you can be pretty confident that the treatment is probably doing the right thing. Let's change it up a bit. Let's say the patient has had 2 seizures in 10 years. Okay? One 15 years ago, another one 5 years ago, and that's all they've ever had. But decision was made to start them on treatment. And 1 year goes by. Are they controlled? Well, it's hard to know because you don't know if they would have been fine, seizure-wise, without the drug. Okay? So what I try and do is look at the seizure frequency before treatment and try and look at it after you've started treatment to get some idea of how long do we have to go seizure-free before we know that we probably did the right thing. Okay? Now, there's a rough rule of thumb, okay? And it has to do with statistics and math and things like that. So, and I don't want to make this too complicated, but let's suppose the longest seizure-free interval before treatment was 1 month. Let's say 1 month. It's the longest they ever went without a seizure. If you do something and they go 5 times the longest interval before, seizure-free. So if we do something, start them on a new drug, and they're 2 months seizure-free. No, if they're 5 months seizure-free, you are probably at 90 to 99% sure that that treatment actually did something good for the seizures. So getting back to this, the person who sent the question in, if there was a high seizure frequency before, medications have been started, adjusted, and now they're 1 year seizure free, it sounds like whatever the adjustments were made did something good. Are they out of the woods? Too soon to tell.
Okay, excellent, thank you. So I have, I think, 2 more questions. Just trying to find one of them. So is the reason you guys use flashing lights in EEGs, is that just to help see if someone's photosensitive? Is there another reason behind it?
Yeah, that's good. Yeah. So in the activation procedures, there's the hyperventilation where people for 3 minutes or whatever, and then there's the photic stimulation. There is a very, very specific type of epilepsy that the brain is sensitive to photic stimulation. It is a very, in the big picture of all epilepsy, it's a very tiny sliver of all of that, okay? So it's one of those things that sometimes we talk about it in the lab, you know, should we keep doing this? Because it's a pretty uncommon thing to begin with, and it's you know, it's a pretty safe test and all that. But you know, if we do 1,000, let's say we did 1,000 EEGs in a year, how many of them will show what we call photic sensitivity? In other words, that there will be a clear abnormality in the EEG with the strobe light. It's going to be a tiny number, okay? Maybe I'm just guessing here. Maybe it'll be 10, 20, maybe 50, maybe, I don't know, something like that. But it is not a common condition to begin with. But, so there are some people who wonder, maybe we don't need to do this all the time anyway. But it's still part of the initial screening EEG that virtually everybody gets. And but if somebody came along and said, it's against the law to do photic stimulation anymore for some ridiculous reason, we probably wouldn't miss it that much, okay? That much. But it is helpful for certain types of epilepsy and certain individuals.
Definitely. I can attest to that.
Yeah.
There was also questions, so another one popped up on the chat. From Robert asked, does certain types of seizures and what happens during it to help? So with certain types of seizures, what happens during it to help point to a specific area to study?
I'm not quite sure I followed the question.
I think like, so if you EEGs, if the seizure happens and like it appears on the electrode, I'm not sure. Robert, did you send that through again? Maybe
rephrase it or something?
Yeah. In the meantime, the other one was, you mentioned, from Andrew, he asked, you mentioned location. Would you say that tonic-clonic seizures start in a specific location or the brain as a whole itself?
Okay, so let's say I hear a noise next door. And I open the door, and there's a person having a generalized tonic-clonic seizure there, okay? So I didn't see it from the beginning, and I won't know if that seizure started in both sides of the brain at the very beginning. In other words, that the forest fire was all over the forest all at once, or did it start in one part of the brain and then spread? And so, in other words, somebody who has a tonic-clonic seizure or a convulsive seizure like that, or the old term, a grand mal seizure, you don't know if you come in the midst of it, if it was a focal onset from the beginning or generalized from the beginning. And that is one of the ways that EEG is so helpful, because that person, if they come for an EEG, they might show on their 30 minutes of recording, even without having a seizure, focal abnormalities that would suggest the seizure was triggered from a restricted part of brain, or they might show the EEG pattern that is characteristic of people who have generalized seizures from the onset. Okay, so that is one of the ways the EEG is really, really helpful. And the patient might say, well, so what? Who cares? Who cares whether it's generalized from the beginning or starts in one place and then spreads? Does it make a hill of beans difference? Yeah, it does. Because there are certain medications that might be picked at the beginning, early in the patient's course, if they're going to be treated. You might have a slightly different pecking order of drug for the focal onset versus the generalized onset. The other thing is the people with the focal onset, you will investigate them differently to see if you can figure out why is that part of the brain so irritable? Why is it generating seizures? We would use an MRI scan with special techniques to really hone in on that little area to say, is there some explanation there for this? Whereas the person who has the generalized seizures, most of those individuals don't need an MRI scan to begin with. They don't have, there's nothing to be looking, you're not looking for anything for that. So so I tend not to over-investigate patients who have generalized epilepsy that looks, smells, tastes, and behaves like a person with generalized epilepsy, who's had a beautiful response to the first drug they've ever had and has no troubles. So we don't, so that's one of the reasons why, or excuse me, not why, it's one of the reasons how the EEG is helpful in deciding further investigations and medication.
Okay, excellent. So there is 2 more questions plus Robert rephrased his question.
Okay.
This question was, so before you get hooked up to an EEG and if you have several seizures, does the type of seizure help determine what area to focus on? So like where the calm seizures, where the whole body is shaking, or something else? To help determine where you guys look.
Yeah, no, when a person comes with EEG, as we spoke about before, everybody pretty well gets the same electrodes, okay? And we kind of do a screen of looking everywhere. Once in a while, there are situations where we see an abnormality, and again, just for discussion purposes, let's say it's up here in the left frontal area. And let's say we want to, for some reason, be a little more precise. Sometimes we will end up putting extra electrodes in that area on future or subsequent recordings, all right? And there's some reasons for doing that, but we don't do it that often. But usually a person, everybody gets pretty well the same electrode set on their first EEG, no matter what they've had before.
Okay. And someone asked, is it true, Kyle asked, is it true if you go for so long with those seizures that you are allowed to drive and will get your license?
Yeah, we've strayed into a completely different area, okay?
Yeah.
But the Registry of Motor Vehicles in Nova Scotia and in PEI and every province, driving is a provincial regulation, okay? So that what's true in Nova Scotia may or may not be the same in New Brunswick, okay? And what's true in Nova Scotia may not be what's true in Arizona or New York or Germany or whatever. Every different areas have their own rules about this. So yes, there are some guidelines on this, and it's the Registry of Motor Vehicles has a list of conditions, and they're quite extensive, and they try to cover lots of different situations. And so a person who's a professional driver, driving 18-wheelers, big transport trucks, is looked at differently than a person who drives just around town or whatever. And how long has the person had seizures? How long have they been seizure-free, et cetera, et cetera. So there's a whole bunch of those things, but they're all spelled out by the Registry of Motor Vehicles. And it should, I don't want to go into this too much because we were supposed to be talking about EEG, but it's a really important thing for patients to understand that physicians are not legislators. We don't make the rules. We are not cops. We don't enforce the rules. But we do have an obligation to teach patients and tell patients what the rules are, right? And help the patient and the motor vehicle people come to the right decision about whether a patient can drive or not drive. And it's often, as probably as the listeners can appreciate, this can be a very unpleasant and heated discussions. Okay, but there's the patient, safety of society has to be taken into consideration. Okay, so the getting back to the question, can people who've had epilepsy in the past, if they've been seizure free for a period of time and blah blah blah, other little bits and pieces, can they resume driving a motor vehicle? The answer is yes, but typically what it takes is a visit to a neurologist, a letter to the Registry of Motor Vehicle that states all the facts of the case, and then the registry makes the decision. The physician in front of you does not make the decision, okay? We don't take away and we don't give out licenses, right? So this is a medical legal area, and it's really important that patients understand that point, because it's very common. Patients come to see me and they say, look, I've been seizure free for 2 years or something, and I want to start driving today, and that's why I'm here for you to give me my license. We don't give out licenses. Okay.
Okay. So the last question, keeping on time, is Leah asked, from Iran, asked, is an EEG a psychological tool?
A logical tool?
Psychological.
Oh, psychological. No, definitely not. For sure. Definitely not. Okay? And I can elaborate a little bit on that. Hopefully we're on the same page about this. One of the big hopes in the early days of EEG was that it was going to be an investigation that would help diagnose and unlock, therefore, certain medical conditions. All right? And I'll take an easy one first. Let's say somebody with migraine, okay? Somebody who is perfectly well, okay? Perfectly well and healthy, but then over the space of a few minutes develops an attack where they get sick to their stomach, they are vomiting, they have a terrible throbbing, pounding headache. This is a brain problem, and then the attack is over, and then a day or two later they're feeling perfectly well. Yeah.
Elia just messaged, I said the wrong word. She asked, was it physiological tool?
It is absolutely a physiological tool. It measures physiology. In other words, how the brain is working. Okay.
All right, sorry about that.
That's right. Yeah.
No, I mean this word. He had.
But maybe just I'll take the opportunity to elaborate just a little bit.
Yeah.
So my point here is that there are lots of disorders in medicine, in neurology, that occur without obvious brain problem, in the sense that if you take a patient who has a history of terrible depression, a patient with migraine, a patient who has had schizophrenia, a patient who has manic depressive disease, etc., and you look under the microscope of those patients, typically you don't see something wrong with the brain, okay? When you look at it that way. In other words, and same with lots of different types of epilepsy. You look at the brain of a patient who's died, who has had lots of different types of epilepsy. You look under the brain under the microscope, you do not necessarily see any abnormality even under the microscope. So that doesn't mean there was nothing wrong with the patient's brain. It just means that using that technique of looking under the microscope, you don't see anything. So these are examples of patients who have disorders of messed up physiology. In other words, how things are working. And it was hoped that a physiology test, EEG, would be useful for making maybe a diagnosis of schizophrenia, of depression, of migraine, and other things like epilepsy. And it turned out it's not very good at any of those, okay? It's not a good test for migraine. It's not a good test for psychiatric disorders. And there's no psychiatric disorders that depend on an EEG for the diagnosis and so on. And that was a really disappointing aspect, I think, for a lot of physicians in the 1950s, 1960s, as EEG techniques were being developed. Well, darn it, why can't we have a test for those disorders? So the hunt continues for ways of doing it. So so if you go way back into the 1950s, 60s, and 70s, there were even in this province there were EEG laboratories at the Nova Scotia Hospital and lots of other places where the EEG was being used in patients with psychiatric disorders, just to see, God, can we help these people with this test and stuff? But it really doesn't have a role in those disorders any longer. At least the way we normally do EEG. Okay. Now, just maybe we're probably getting near the end, but we started at the very beginning talking about maybe things in the future. What else is there something way we can milk more out of an EEG, right? With computer techniques. Maybe there is. And there's a lot of time and effort has been expended to try and say, maybe is there some kind of little pattern in the EEG that we can't see with our eyes that a computer can recognize that might be useful for diagnosing some of these other disorders, or for diagnosing that a seizure is coming. Okay, that we can't do that nowadays. But if suppose it was a technique where there was a little signature on the EEG that says this person has an 80% chance of having the seizure 5 hours from now. Okay, people are working towards that kind of thing. It's a little bit like trying to predict earthquakes, right? People look at seismographs of the earth crust moving and so on, and saying, can we use this information to predict when an earthquake is going to occur? So the same idea of mathematical analysis of very complicated waveforms, what can we predict when a seizure might occur? Anyway, in our lifetime, maybe we will. So.
Okay, fingers crossed.
Fingers crossed.
So yeah, that was all the questions. Thank you everyone, Dr. Sadler, for everyone and Dr. Sadler for doing this, joining on. Thank you everyone for sending your questions through. Very good questions. Dr. Sadler, do you have anything else you'd like to add? Any advice or any last words?
Nothing really, other than I was very, very pleased and honored to be asked. Okay, it's nice, and I also but more importantly, hopefully it was a little bit useful, and I hope there were some things there that help people understand a little bit about what this test is about, what it's good for, what it's not good for, why does it fail us, how does it help us? Okay, all right.
Excellent. Thank you so much. This was
if you get some feedback, Cassidy, from people that could have done this better, could have done that better, whatever, please let me know. It's the only way we get better at this business, if people are honest and tell you this was crap or this was good or whatever. So okay, all right.
I will let you know, but I think me per se, this is very fascinating, very informative. I'll let you know if there's any feedback.
Okay.
But we definitely learned lots, and thank you for working us into your busy schedule and doing this with us.
Happy to. Okay. All right. Stay safe, everybody.
Stay safe, Dr. Sadler. Everyone's going in the comments saying thank you very much. It was excellent. They learned a lot. A huge help. All good feedback so far.
Okay, very good. Okay, cheers. Thanks very much. Bye-bye now.
Have a good day. Be safe. We'll talk soon, guys.
I feel stronger than before. I'm not alone anymore. I look up and